action that happens in the bottom of the box that will cause injury to the rubber dam or will cause injury to the interdental papilla will injure only the wedge, not the rubber dam. So we protect our interdental papilla and interdental damming, okay? At this picture, if you see, I did use a special type of wedge called wedge with shell. This is an expensive one. You can do it yourself. Take a matrix and a wooden wedge, normal wooden wedge. The matrix, you put the matrix between the teeth and then add the wedge and everything will go okay. This is very important so as not to injure the adjacent tooth if it's intact. If you injure the adjacent tooth when you do your preparation to the 6 here, okay, this will increase the surface energy of the adjacent tooth without causing any interrupting in the morphology of the tooth. Only increase the surface energy because it becomes rough. This will lead after 1-2 years to accumulation of bacteria and caries, class 2 caries on the adjacent tooth, the premolar in this case. Okay, so it's very important to shield, to protect the adjacent tooth from our drilling. Okay. Is there any question, Doctor? No questions? Okay. Another trick.
No, Doctor, for now, all is okay. We don't have any question.
Okay.
All is fine.
All is fine. So, how is the English? Is it good or rusty?
Very good, thank you. Very, very
okay.
good, don't worry.
Alhamdulillah. Okay, the second thing that we use is the flossing. Every clinic have the floss. We do flossing every day, and I don't do flossing, unfortunately, but we have to do flossing, and you have to have a floss in your clinic. So what's the use of dental floss? Here, I did not a knot, I did tie a tie, okay, and hang the tooth. I did hang the tooth. So what's the importance of dental floss? Okay, when you tie the tooth with the dental floss, it will retract and fixate the rubber dam. What's the meaning of retracting the rubber dam? It will expose more of the tooth structure and it will cause the clavicular fluid to seal the cavity or to seal the tooth or to seal the damming area from the clavicular fluid. So it will help you by 3 means. Okay, retract and fixate the rubber dam and expose more of the tooth, like we will see now in the pictures, and seal from clavicular fluid. Here's some picture, okay? This is when we tie the dental floss around the tooth. Look how much of tooth structure we exposed here. And the second picture will show you the differences between, okay. The differences between the flossed area and non-flossed area. Look how much we exposed from the tooth structure. And we exposed the intact tooth structure beyond the level of the carious one. This is what we want when we do our restoration. We need to have a full view of the tooth, the defected tooth, okay? And last, we use Teflon and Liquidam. Teflon, it's the magic, okay? The Teflon tape can be bought from the any supermarket or any place that you want, okay? The Teflon is a magic. You can press it and compress it and put it wherever you want and it will seal, okay? For the Liquidam, you can use the flowable Liquidam that found on the bleaching kit, or you can use any cheap flowable composite, normal flowable composite, cheap one, to seal the gaps that happened when you do your damming. Sometimes the tooth surface is irregular and the rubber dam clamp will not seal everything. So when you use the Teflon to close it, or you can use the Liquidam or the flowable composite, cheap flowable composite, so as to close the area. And you can use also the sticky wax that used in ortho. if you know it. You can use it the same way as shown in the pictures here. Here I use the liquid dam, and you can use the sticky wax also. And here I use the Teflon. I can compress it, and here at this picture I use it to I compress it here and use it to reshape and modify the matrix here to recreate the margin here, the mesial margin. Yeah, mesial margin. Okay. So we finished about the technique sensitivity. Is there any question? Okay.
All is fine.
Okay. Now we are get started with the preparation of the tooth. Previously, we have a saying that said extension for prevention at the amalgam era, okay? Extension for prevention is to remove more of the healthy tooth structure so as to achieve the physical retention of the amalgam restoration. This is an old day, okay? This is an old fashion. Now we have to prevention of the extension because we have a composite material, a new era of material that bonds chemically to the tooth structure. So we don't have any we don't have to do any physical means to retain the restoration. We have the bond, we have the new material, and everything is okay. So during the removal of the caries, we have to remove only the defective tissue and the weak tissue, not the unsupported tissue. And we will show later on why we have to remove the weak tissue, not the unsupported tissue, and we have to differentiate between both of them. Next slide, we will show it to you. And we have to remove the carious tissue, the defective one. How to know what's the, okay. The computer is always jamming, I don't know why. Okay. How to know that we are removing the carious tissue, how to know that we have removed every carious tissue, not the healthy tissue. We have many methods. You have to have at least 3 of them. One of them, I think all of us have it, is the eyes, is the visual and tactile method. You have to use your eyes, you have to see, okay? The second one is the radiograph, mainly bite wing X-ray. So to know and to identify the area of caries and the extension of it. The third one, which I use in my clinic, and those are the 3 main things I use in my clinic. The first 3 here I use in my clinic, okay, is the use of caries indicator. Caries indicator or caries detecting dye is a small bottle that contains a dye that will stain only the organic material, the bacteria, okay? Sometimes it is rhodamine B or methylene blue, whatever. How to use it? I will, in short brief, I will show you how to use it. First of all, after I did clean my tooth by using the burrs, okay? Then I check with the probe, everything is sound. I bring a cotton pellet and soak it in the sodium hypochlorite. Sodium hypochlorite, listen. Sodium hypochlorite. I repeat it 3 times, okay? And put it on the tooth and rub the tooth for 10-20 seconds. Then I wash it with the triple syringe for another 10 to 20 seconds. Then I apply my detecting dye, okay? After I apply it for 10 seconds, or as recommended by the manufacturer instructions, I remove it with a triple syringe. The remaining stain on the tooth structure will show me if there is any caries or not, okay? Why did I use the sodium hypochlorite? We all know that bacteria has bacterial byproducts, and the bacterial byproducts will also stain by the stain, okay? So in order to decrease the false positive results from the caries indicator, I use the sodium hypochlorite to remove as much as I can from the debris and the bacterial byproducts. Everything is clear here? Okay. After I wash it, there will be some stains that is very deep in color. This is a caries. some stain are very light in color. If I found the light one and remove it with the sodium hypochlorite again, and it's removed, everything is okay. It's not a caries, okay? But if it's not removed by the sodium hypochlorite the second time, it's caries. Remove it with a low speed without water at low RPM, let's say 5,000 RPM, okay? Next, trans-illumination, or the use of special lights. Many of the lights now in the clinics, the light cures has a detect mode. The detect mode will show a color for the caries, and an amber color or a violet color, something like this. It depends on the company. So it's a good way, but it's not an accurate one, okay? But if you have it in your clinic, it's good to show the patient that he has a caries or she has a caries, okay? And the final method is the use of special imaging devices. It's very expensive. I don't use it. I don't see it. And I didn't see it in my life, and I will not see it in my life, inshallah. It's called the Spectre. You take a photo and it analyze it in a wide spectrum of light and colors. Every color have a meaning, like the green color have sound enamel, let's say. Blue is initial caries, beginning of enamel caries, and blah, blah, blah. It's very, very complicated, and it's not recommended for me. Now, we said before about the weak enamel or weak tooth structure and unsupported tooth structure. What's the difference between the weak and the unsupported? The weak one, we don't want it, because under the contraction and the shrinkage of the composite, it will break. Many of us did restorations for the 4 and the 5, the premolars, for the upper or the lower, and it was an MOD. And after we finished our restoration, we noticed a crack in the enamel, not in between the tooth and the restoration, or the restoration itself. On the enamel, on the cervical area of the wall, okay? Labially or palatally, it depends on the wall thickness. So what's the weak here? The weak enamel here is the wall thickness less than 2 millimeters. If we have a remaining tooth structure with a thickness less than 2 millimeters, it's considered to be a weak one, okay? Weak means that it will break under the stress and shrinkage caused by the composite after polymerization, okay? So at this case, I will show you at the case. At this case, this patient came to me, and she wants to replace the amalgam restoration. After I saw this restoration, I suspect that it might have a weak cusps with less than 2 millimeters of thickness. So immediately after I did the isolation, I took an impression so as to remake a stamp, or to make a special stamp for this patient. Because this wall, if I lost this wall, or if it's less than 2 millimeters in thickness, I will reduce it. I will prepare it so as to cover it with the composite. So I did take an impression, then I cut the impression before I initiate any drilling, and check the impression to if I have to remove this wall. This is the susceptible wall for weakness, okay? So I have a reference for me to recreate the wall at the same dimensions that the God created, okay? But after I did my preparation and examined the thickness was more than 2 millimeters. So everything went okay, and everything is done correctly without the need of any reduction of the height of the walls. Okay, so we have to repeat it. The difference between weak and unsupported tooth structure. The weak tooth structure is any tooth structure with less than 2 millimeters in thickness. Like in this case, you see the cusp. If it's less than 2 millimeters, I have to reduce the height of this cusp so as to cover it. I will reduce it with 2 millimeters in height, okay, and cover it with an overlay, either a composite one, immediately, direct, or indirect way with the ceramics or whatever, okay? The unsupported one is this one. This is unsupported, means unsupported that there is a loss of tooth structure around it, but if I did put the composite around it, it will be supported, okay? This is unsupported, I will leave it alone and complete it with the composite. If it's weak, it will be less than 2 millimeter. Everything is okay. I repeat it 2 times because many in my lectures all the time they ask about this many times, okay? Everything is okay here? Understood?
I think yes, all is fine.
Tamam. Okay, this picture has some relation to the topic. Okay, this picture shows the restoration of an endodontically treated tooth. In my opinion, the endodontically treated tooth should not be crowned every time, okay? When it should be crowned? At the last case, okay? This one. When we did a total build-up or core build-up, then you crown it. If you have it in this case like this, or this, or this, or this, you have a valuable enamel here. Okay, the unsupported enamel, if it's less than 2 millimeter, you have to reduce it. I'm with you. But if it's unsupported, not weak enamel, and it's more than 2 millimeter, why you have to prepare it? If you prepare it, you will make it weak and it will break. So if you have this case, or this case, or this case, or this case, with a minimal preparation with endo, like tapering 0.4 millimeter, okay, you have to do a restoration only, or a tabletop with the composite restoration, even direct or indirect. Don't prepare it for a whole ceramic or any kind of crowns, okay? At this case and this case, this case and this case, okay? Don't prepare it because you will lose everything. Okay, the minimal preparation is 0.5 millimeter. Okay, if you remove 0.5 millimeter from this 2 millimeter thickness, you will have only like 1 millimeter, 1.5, 1.4 millimeter. It's very weak. It will break. Okay, so use the valuable enamel. Use this valuable enamel. Okay, next. Okay, should we use liner or any bulb capping material? For me, if there is no perforation or micro perforation, the bond is the best liner it can be, okay? But if we have a shadow of the bulb, if you don't have a bleeding, there is a micro perforation. So you have to do a capping, even if it's a direct or indirect bulb capping. Okay, many of the practitioners use the die-cal, but recent studies showed that die-cal is not recommended anymore because it has a bonding strength to the dentine with 0 power, okay? There is almost 0 bonding strength for the die-cal, which is calcium hydroxide, to the dentine. So when you do your restoration and apply the bond and blah, 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 the composite will shrink toward the center. So it will pull the die-cal or the calcium hydroxide from the tooth structure and create a space. This space will translate it later on with a sensitivity upon the pressure immediately after the patient leave your clinic. So the use of die-cal now is minimized, and I honestly, myself, I don't recommend it. Okay, so what's the substitute of die-cal? There is many substitutes. Some of them are wait. Okay, wait. Okay, now glass ionomer or calcium lining material. So usually I ask a question, what do you use, glass ionomer or calcium lining? But there is no one participated with me, so I will ask myself. Okay, glass ionomer or calcium lining material? For me, I use the calcium lining material. Why? Because of the pH. We all know that glass ionomer is acidic in nature. So the acidity of the glass ionomer will irritate the bulb, first of all, and also it's a favorable media for the bacteria to grow, okay? And also the glass ionomer reaction needs water to complete its reaction. So where he will find the water to react? From the dentinal tubules. And this will irritate the bulb more and more and more. Okay, so I use the calcium lining material, mainly the Theracal. Okay, the Therical LC, Therical light curve from Pisco, or the Biodentine. We don't have Biodentine in Palestine, so we use the Therical. Biodentine here is very expensive, and you have to use the whole capsule at one time. You can use it by put it on the amalgamator and use it as a whole restoration for 48 hours. After it's set, the patient will come to you and you reduce it for 2 millimeters or something or so, and use it as a lining or a base and put composite above it. So it's time consuming. The patient came to you 2 times or 3 times, and it's also expensive. Okay, for me, the Therical is the king. Therical, you can use it wherever you want and however you want. It's very controllable and easy to use. But a lot of dentists said, when I use the Therical, the patient came to me after 1 month, 2 months with necrosis because we use it wrong. How to use the Therical? The Therical is used like this. The tooth should be wet, shiny wet, not dry wet. That means it has to have a little bit of water or moisture on the dentine, okay? A shiny one, you have to see it. Okay, not a pool like a lot of water. No, a drop of water or so. After you put the Therical, okay, cure it for 2 seconds, then leave it, then leave it for 5 seconds, then another 3 seconds. It will sit, but not finally sit. Okay, why we use that? Because any reaction needs the light cure or photopolymerization. It's an exothermic reaction, so it will generate heat, and this heat will cause necrosis for the pulp, because any heat. I did this test on my students in the clinic. I put a drop of flowable composite on their fingers and light cure it for 5 seconds, 10 seconds. They will feel the heat. Any heat that you feel it on your finger, it's more than 40 Celsius degrees. So it will cause necrosis for the pulp. Okay. So after I use it for 2 seconds, then rest for 5 seconds, another 2 seconds, it will set. Then I put water on the cavity. I soak it in water, a lot of water, then complete my curing. This is the right way for using the Therical LC. Okay, any questions? Any questions?
Someone is asking, if our cavity preparation is deep, then is it appropriate to use calcium linking material followed by GIC?
Okay, you can use it, but why you use different phases? We need to minimize the phases so as to achieve a bulk fill with a single material, mono material. Okay, if we use the Therical, then we use the glass ionomer, then we use the composite. The bonding surface for the composite is now very little in area, so we don't have a good bonding. Okay, so to achieve a good bonding, we have to have all the surface available for us. So why to use different materials? Okay.
Okay, I think you answered the question. Okay. No more questions for this.
About the technique for Therical, everything is okay? Everything is clear? If you want me to repeat, I will repeat.
I think it's okay. We don't have any question.
Okay. All the participants are geniuses. Okay. So we finished about the getting ready for the restoration. Now the procedure. First of all, I will pass it quickly because it's obvious.
Sorry,
and easy.
Doctor, I'm sorry, I want to interrupt. Someone is asking to repeat the technique, please. If you can repeat it.
Okay. First of all, when you use the Therical, the dentine must be moist, shiny, moist. Means that we have to have some water on the surface. Okay. Then we apply the Therical. We cure it for 2 seconds. Then rest for 5 seconds. Rest without doing anything. After that, 2 seconds. If we check it with the probe slightly, don't force the probe, it will be seated, but not like fully seated. Okay. Then we apply water and fill the cavity with water. After that, we apply the 20 seconds cycle of polymerization. This will set the therocal completely without elevating the heat, without rising the heat of the therocal, because it's the exothermic reaction. Okay, everything is okay now?
Yes, thank you.
Okay, so next we have to start with our restoration. The steps for our restoration is acid etching, bonding, polymerizing, and filling. Okay. The acid etching, there is a different technique between in acid etching, the total and the selective one. What's the differences between total and selective one? Before that, we have to consider that the tooth is constructed of two main structures, the enamel and the dentine. So the enamel consists of 96% of inorganic material, hydroxyapatite crystals, and the dentine consists of 70% of hydroxyapatite crystals and 20% of collagenous and organic material. So there's a different structures, so we have to treat it differently. The more hydroxyapatite crystal content in the enamel means it's a very hard substance, okay, and the bonding and the procedure will be predictable for it, okay, but for the dentine it's moist and the bonding and the procedure is unpredictable. Another thing we have to consider is that the enamel have a module of elasticity of 84%, 84 gigapascal, okay, but for the dentine it's 18, okay. So the difference between the module of elasticity will also affect the restoration that we used. Now we will talk about it. So let's say etching of the tooth. So the more inorganic material, the more hydroxyapatite means it can be we can do acid etching without any fear or any consideration of anything else. Okay, but for the dentine, because it's a living tissue, we have to be cautious. Okay. At this stage, timing is the most important thing. For me, I did use the total and the selective etching, both of them, but not exceeding more than 15 seconds in total time, okay? So I did the etching for 15 seconds, mainly for the dentine. For the enamel, I can reach up to 20 to 30 seconds. It doesn't matter, but for the dentine, you have to do it for most, for 15 seconds at most, okay? Why? Because in the dentine we have the smear layer. We all know the smear layer that formed after the preparation of the tooth. The smear layer consists of the smear layer itself and the smear plug here. Okay, so when we do our acid etching, we can modify or remove the smear layer, but we don't want to change anything about the smear plug, because the smear plug is the one thing that separate the dentinal tubules and its fluid and the bulb from the outer environment that will be in contact with the bonding and the composite that we use. So we don't want to have any communication between the dentinal tubules and the composite and the bonding that we use. Because this will cause a sensitivity immediately when the patient leave our clinic on mastication. Okay, on mastication, immediately after the patient leave our clinic, he will feel pain on mastication because of the over etching of the dentine, because we remove the dentine plug, the smear layer plug. Okay, so what should we have? We have a selective etch or total etch technique. The total etch technique, we start with the enamel. We put the acid etch on the enamel. After we finish the application of the acid etch on the enamel, we start with the dentine and we count 15 seconds. Okay. After the time finished, 15 seconds, we will have copious irrigation for 30 seconds. Okay. So we apply acid etching for 50 seconds. and 15 seconds, sorry, and we apply the water and the air with the triple syringe for 30 seconds, twice the time of etching. Okay, it's very important. And this is for the total etch. And for this is a picture showed the total etch here. I prefer always to use the selective etch, but at this case, particularly this case, the cavity is too small. And when I put the tip of my applicator tip of the acid etch on the bottom here, the viscosity of the acid etch is not like we apply a viscous gel. It has a low viscosity and will spread toward the dentine. So I use the total etch and count 15 seconds immediately, okay? Because of the size of the cavity, and the acid etch will always reach to the dentine without any means, okay? Then the selective etching. The selective etching is to apply the acid etch only on the enamel for 15 to 20 seconds, and we rely on our bonding system that contains the weak acid etch on it to etch and modify the dentine, okay? And the same, after we apply it for 15 to 20 seconds, we did the triple syringe move for 30 to 40 seconds, twice the time of etching. Let's see the pictures here. Why I recommend 15 seconds here? I recommend 15 seconds here because, as I said before, I put it on the enamel, but the viscosity and the gravity cause it to slide toward the dentine. So in order to avoid any damage to the dentine and any damage to the smear layer, any unnecessary damage, I apply it for 15 seconds only, maximum 20 seconds. And this case also. Another case. Okay. After we apply the acid etching and remove it with the triple syringe, we have to dry it. Okay. But before we dry it, we have to consider something very important called the matrix metalloproteinase enzyme. What's the matrix metalloproteinase enzyme? It's an enzyme that found normally at the dentino-enamel junction. The tooth produce it as a result of acidic attack, mainly from the caries, but at this case from the acid etching, that will cause hydrolysis of the collagen, mainly collagen type 1, that we use it in the hybridization and bonding of the dentine. So after 4 months with your restoration, the patient will come back to you and say, the restoration was doing good and everything is good, but after 4 months, I feel a pain on the mastication. Why? Because the bond is aged, because of the matrix metalloproteinase enzyme that caused debonding for the dentine, not the enamel. The enamel is very predictable, everything is okay, but the dentine here, because of the matrix metalloproteinase enzyme that caused hydrolysis and lysis of the collagen, caused debonding and destruction of the hybrid layer, okay? Another thing that we have to take in our consideration, okay, is the water chasing effect. The water chaser, what's the water chaser? Every bonding system have a solvent that may be water or ethyl alcohol or acetone. What's the idea of the solvent? The solvent is the vehicle that take the bifunctional monomer of the bond and deliver it to the collagen that found on the hybrid on the smear layer, okay, to cause the hybridization. Without any water in the dentine, this solvent will not find the media that he can move and deliver the bifunctional monomer to the dentine. So when we do our drying, we don't use the triple syringe, the air alone on the drying, because if we over dry it, it will cause the collapse of the collagen and also will remove the water and remove the media that the bond will move in it. So it will have no bonding to the dentine. So how do we dry the dentine? The dentin can be dried by the foam pellet that found on the Guttapercha bucket, okay? Or we can use the cotton pellet, we can use the suction, and the best way is the use of a bond brush, dry one. We put it on the cavity after we apply the acid etch and remove it, okay? We put it on the cavity, and on a tissue, we stamp it. If it has no trace of water in it, this is a good drying for the dentin, okay? Don't over dry the dentin because you will lose the bonding to the dentin. Everything is okay? There's a lot of information, I know. It makes me dizzy also. This is the thing that we talked about earlier, the aging of the dentin, the aging of the bonding, okay? How to counteract the aging, how to prevent the activity of the matrix metalloproteinase enzyme. We can use the chlorhexidine gluconate diluted in water in 2% water, 2% in water, okay? After acid etching before bonding, and we dry it as we dry the previously, as we said previously, with the bond brush, dry bond brush or cotton pellet or whatever, okay? It will not affect the bonding, but it will prevent the formation of matrix metalloproteinase enzyme. Or sometimes some of the companies produces acid etch with benzalquinone chloride. This is an antibacterial that also prevent the formation of matrix metalloproteinase enzyme. It's more powerful than the chlorhexidine, okay? Some of the companies like Pisco, it produces a acid etch called acid etch HV, I think, and it contains the benzalquinone chloride, okay? And you can use at this stage before bonding, you can use the desensitizer. It will not cause any effect on the bonding, and it's good for desensitizing and reduce the sensitivity of the dentin. Like glutyraldehyde, it's a glutyraldehyde gluconate from Gluma, like this, or from Danville, okay? I use this in my clinic, the Gluma one. Everything is okay about etching? So the etching should be only 15 seconds for the dentin. And if you use total etching, please do it for 15 seconds only, okay? Because we don't want to remove the smear plug. And after acid etching, you have to use the chlorhexidine, okay? Chlorhexidine gluconate 2% in water in order to inhibit the formation of matrix metalloproteinase enzyme. This is all you have to know about acid etching, okay? After that, the bonding. The bonding can be classified in too many ways, okay? We have this classification, 3 steps, etch and rinse, and 2 steps, self-etch. The gold standard for all of them is the 4th generation and the 6th generation, okay? The 4th generation for 3 steps, etch and rinse, okay? And the 6th generation for low self-etching and who self-etching bond, okay? So let's talk about it. Okay. The 4th generation, which is the gold standard, you have to etch the tooth, then prime it. The primer is in a separated bottle, and you have to apply the adhesive after that. This is a time consuming, but it's the gold standard. You will achieve the premium, the most of your bonding during using of the 4th generation bond. It has an annual failure rate of 3, I think annual failure rate here. Where is the annual failure rate? Okay, it has a retention rate of 94% after 13 years. Imagine after 13 years, your restoration is good and it's 94% good. What do you need more? Okay. This is an example of the 4th generation, the OptiBond FL. The FL here means that it's filled. It's a filled bond with a 48% of filler inside the bond. Okay, it means it's a good bond, and it will cause less sensitivity and less degradation with time. Okay. And this is the 6th generation. The etch and prime is in the first bottle, okay, and the bonding in the second bottle, and it also has a good success rate with the 96% retention after 13 years. Imagine that. The 6th generation, 4th generation, and the 6th generation is the gold standard. With both of them has a 4.8 to 4.7 annual failure rate. This is a very good bonding systems. Okay, this is a Clearafill SE, and there is also Clearafill FE. With the FE means it contains fluoride also from Curary, I think. Okay, and finally, all of us know that the universal bonding. We have to distinguish between the universal bonding and the 7th generation bonding. The 7th generation bonding is the one bottle system bonding that contains the acid etching, primer, and bonding, but it's not necessarily a universal bonding. The universal bonding means it contains the 10 MDB. It's the bifunctional monomer, which has the both hydrophilic and hydrophobic path. And also works with nano layering and cause a chemical bonding to the tooth structure, to the dentine mainly. Okay, this is the universal bonding that contains MDB. And recently there's a new product from Dentsply-Sirona that contain another bifunctional monomer rather than MDB called pentafunctional monomer, which has 4 times more covalent bonding link to it, and it's 4 times more resistant to degradation than the universal bonding found now. Okay, so universal bonding contains MDB. 7th generation bonding the same, but not containing the MDB component, and also the 7th generation is the weakest of them because it degrades. And also, as we say here, blah, 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 hydrophilic, blah, blah, blah. Okay, we will see it later. Hona. Okay, and the 7th generation bonding will serve you for 2 years, and after the 2 years, it will drop drastically. Okay, the bonding strength will drop drastically, and it will cause sensitivity after 2 or 3 years from the application of the bond and restoration. Okay, everything is clear. I feel a little bit dizzy. I'm talking to myself.
All is clear. Some of the participants are asking questions, but I will leave them to the end of the session because they are not related to the current topic.
What's the question?
It's about sensitivity, post-operative sensitivity.
Let me hear it. I need someone to talk.
Okay.
I'm talking to myself.
So we have 2 questions. The first is about calcium release. Is it true that the calcium release from TheraCal is less than DiCal and MTA because TheraCal is resin-based?
It doesn't matter, yes, but it doesn't matter. You know, we have a very main driver for us to use the TheraCal. The TheraCal bond to the dentine with 4 megapascal strength, but the DiCal is 0. So the TheraCal is more stable. You can apply it more carefully and more predictably. The DiCal is not. Okay, so it doesn't matter about the release of calcium if you lose your bond to the dentine with the DiCal versus the TheraCal. Okay, so I need to use the TheraCal because I predict how it will behave in the dentine, not like the DiCal that will cause because of the shrinkage of the composite. It will leave the dentine and form a space between the dentine and the DiCal itself.
Okay, the second question is if the patient comes back after a few months with complaint of sensitivity because of smear plug loss or enzyme, then how to manage that case?
Because the smear plug will came to you after 1 or 2 days. Okay, the pain is immediately after the patient leave your clinic. But if he means the aging of the bonding layer, he will come after 4 months, because the process of hydrolysis takes up to 4 to 6 months. Okay, how to manage it? He needs to redo the restoration, refresh the margins, the dentine margin, and rebond all over again. Okay, with the use of chlorhexidine or benzoyl chloride.
Okay, thank you.
Welcome. Now let's say about the polymerization. Shortly, the polymerization, we have to know the type of photoinitiator that found in our composite and in our bond, and we have to know that there is a self-cured bond and photopolymerized or photocured bond. Those two things is very important. We will say now. The photopolymerization is a process initiated by the light that will hit the photoinitiator that found on the bond or on the in the composite itself. It can be camphor quinone or propandione. The differences between them is the wavelength that works. Okay, so you have to know the light-cure you have in your clinic, that it has the proper wavelengths that will initiate the reaction of our composite. Okay, so now we have in my clinic I have 2 light cures that have dual wavelengths. Okay, the blue one and the violet one. So in your clinic, please bring those light cures, and you have to check your light cure every 1 year, okay, of use, so as to be sure that the light cure is in its full power and function well. Okay. Why we said that we have a chemical cured or self-cured, let's say, and photo-initiated or photopolymerized bond? Because in our clinic we also use the fiber post and the buildup of the destructed tooth with the fiber post. Okay, every ½ centimeter that the light cure tip is away from the material, the cured material, the strength of the light will reduce with 50%. So when we use the fiber post, we will consider the length of the crown, let's say 7 millimeters, 3 millimeters, whatever, and the preparation of the canal, at least 5 millimeters. Okay, so there's a 1 centimeter distance. The light cure strength here is 25% of its all strength, so there will be no light curing for the material within the canal. So you have to use a self-cured composite and bond, like the one in the picture here. This is from Tokoyama. This is a auto-cured 2 bottle mixed together, or if you have a universal bonding, there is a separately activator that you can buy and mix it with the bonding system you have, and achieve your curing on the area that the light cure doesn't reach. Okay. Now we are talking about the filling. The main problem with the filling is the shrinkage, and the shrinkage that will cause stress. So in order to avoid it, we have many strategies. You have to try to apply as many as you can strategies of those. Okay, not all of them, as many as you can. Those strategies are the C factor and the layering and the light curing. This is the 3 main strategies you have to do it in your clinic. What's the C factor? It's the ratio with the unbonded on the bonded. If the ratio is more than 2, the result is more than 2, like in a class 1, and if you have here in the class 1, you have one unbonded surface, so the bonded over the unbonded, 1, 2, 3, 4, and 5, the mesodistal over 1, so the result will be 5. Any number above 2 will cause shrinkage and will cause the restoration to cause problem, like cracks, micro cracks on the restoration itself, and cohesive fractures, whatever. Okay, so how to manage that? By using the layering technique. Using the layering technique by engaging less surfaces less surfaces of the tooth structure. We will see it here in the pictures. Okay, this is the layering technique. Let's say this case. Okay, I remove the caries. Okay, I simplify the case here. I put the wall, the missing wall, in order to achieve a class 1 restoration to make it easy. Then I put my layers. How to put the layers? If you put the horizontal layers, you engage more surfaces over the unbonded surface. So the C factor here is risky. It's more than 2. So you have to do an oblique layering technique to engage less surfaces here, 2 surfaces, okay, over 1 surface. So the result is 2. The C factor here is 2. 2 or less is good. Okay, so you apply the oblique layering technique here. 1, 2, 3, 4, up to the end. Okay, so we have to do layering with less engagement of the surfaces, 2 surfaces or less. Okay.
Doctor, can you please repeat the C factor idea?
Okay, the C factor. You have a cavity. Okay. What's the meaning of C factor? Is the ratio that of the bonded surface over the unbonded surface. Okay, so if we have a class 1, how many walls in the class 1 that you can engage? The floor, this is 1, the mesial, the distal, the buccal, the lingual, 5 walls. Okay, what's the unbonded one? The occlusal. Okay, so 5 over 1, the result will be 5. This result is very risky because if we put a bulk restoration here and do the curing, the stress will cause a microfractures within our restoration, or will cause a cohesive fracture, or will put the tooth under a stress and the patient feel a pain, an unimaginable pain without anything. It's a spontaneous pain because the tooth is very, very stressed. Okay. So we have to do some strategies to overcome this effect. So we have the layering technique with an oblique layers, not a horizontal layer. If we do the horizontal layer, it's the same. The C factor will be 5 or more or less, whatever. More than 2, less than 5, whatever. But if we use the oblique one, we reduces the bonded surfaces over the unbonded one. Okay, like we see here. Wait, here in the picture, look here. This is an oblique layer. This is 1 layer. Okay, how many bonded surface? 1, 2. How many unbonded? 1. So it's good. Here in the horizontal one, how many bonded surface? 1, 2, 3. Okay, so 3 surfaces over 1. The C factor will be what? 3. Here 2. What's the best? 2 is better than 3. Okay. Now, is it good?
Yes, it's clear. Thank you.
Okay. Like we said before at the structure of the tooth, the enamel and the dentine, we said that the modulo of elasticity of enamel is 84 gigapascal and the dentine is 18 gigapascal. What that means? It means that the enamel is rigid material and the dentine is elastic. Okay, it has some elasticity. Okay, so we don't have any problem with the layering on the dentine itself if there is a dentine, because the shrinkage of the composite will be compensated by the elasticity of the dentine. But when we reach the cemento enamel junction, which has a modulo of elasticity with 85%, which is very rigid material, we have to do light curing in a different way, okay? Because if we do a short curing, a full curing for the enamel surface with the composite, it will cause cohesive fracture. That if you know about the cohesive fracture, I say it before, the cohesive fracture is happened between the enamel particles itself. Because of the shrinkage of the composite, the composite will pull the area that bonded to the enamel, okay, and will separate it from the enamel itself, and this will be the white line after your restoration is done. If you see a white line around your restoration immediately after you finished your restoration, this is a cohesive fracture. That is caused because we use the light cure extensively after the final layer of our restoration. How to manage that? By using light curing, pulse delayed light curing. All this talk can be said in 2 words, okay? Light curing, how to use light curing. As we said before about the Theracal, we don't use curing immediately and for 20 seconds for a long time, because it will elevate the temperature of the tooth. So how do we use the light cure? First of all, we do 1 second. Listen carefully. We do 1 second. After we apply the composite, we do 1 second. Then we rest 2 seconds. Then we apply 5 seconds. Okay. What this will do, after we initiate the polymerization reaction, we let the material, the composite, to rest and form longer chain. So with longer chain, there will be more stable and less shrinkage. What's the meaning of polymerization? First of all, the polymerization is the formation of polymer from monomer. The monomer is one particle binds to another particle, to another particle, to another particle to form the polymer. Okay, the longer the polymer chain, the more stable, the less shrinkage. Okay, so how to achieve that? With the pulse delay technique in the light curing. We do 1 second, we initiate the reaction, we let it rest, like we use with the dough. If you do the dough, when you're making the bread, you let the dough rest to form the gluten. It's the same, okay? So you let the composite rest after 1 second of curing, okay? For 2 seconds, this will form chain with a longer chain and less number of a chain. We need it to be less number of a chain and longer chain, okay, to achieve more stability and less shrinkage and stress. Okay, after that, we will do a 5 seconds curing to stabilize it, to make it hard to continue the work. Not final hardening, but it will be resist to change in the morphology after you apply the forces for the second and third and fourth and blah, blah, blah layer, okay? After you finish the 5 seconds, stop. Do another layer, make it with 1 second, 5 seconds. The first layer that you have done will take another 6 seconds of light curing from the second layer, okay? It's like a cumulative. Finally, you have give the first layer, think like 40 seconds of curing, but not directly, with an intervals, okay? This is the light curing technique that I use. Everything is okay?
Yes.
Okay, so pulse delay technique. I will briefly say it again. 1 second after applying the composite, 1 second, rest 2 seconds, then apply it for 5 seconds. Done. That's it. Then another layer, 1 second, rest 2 seconds, 5 seconds. After you finish all the restoration, you can do light curing for 1 or 2 minutes. Okay, 1 or 2 minutes. This is the final curing after finishing, before polishing. Okay. Now we are going to show you some of my cases. Okay, those charts, 2 charts from Stylo Italiano, show you the simple anatomy that you can follow to achieve a good restoration. Look at the anatomy, look at the lines. It's simple lines. If you follow those lines, you will be good. Okay, now the cases. Look at this case. This is the 5, 6, and 7. This is the caries indicator. After that, I did the 5 and the 7 to recreate the contact with the 6. So I finish those. Then I start with the 6. Okay. And this is the final result. Look at the lines. This is a cross. This is a cross. Look at there. The same lines that we saw on the previous chart. Let's go back to the chart. Look, the same lines. This is a cross, and this is the zigzag one. Let's go back. The same lines. This is the zigzag one, and this is the cross, right? It's easy. Another case. Okay, this is the caries indicator. You have to finish one and then start with the other. Don't start with both of them. If you put two matrices here, you will end up with a gap between them. Okay, and this is the end result. Look at here, the zigzag, and this is the cross. Okay. Thank you for your listening. And this is the end. Any questions?
Thank you, Doctor. Very beautiful cases. Thank you for this interesting webinar. Meanwhile, I will ask your permission to introduce our company to all the participants. And I request all the participants to kindly put their questions in the question and answer box if they have any.
Okay. Okay, Doctor.
I will manage the question and answer session at the end. Now I'm going to talk a little bit about our organization.
Okay.
So this is our organization, DentistChannel.Online, Healthy Smiles, Wealthy Lives. I request all the participants to kindly save this number and send a message on WhatsApp with their name, so they will be added to our broadcast list and they will receive all updates about our upcoming webinars, workshops, and courses. So today's webinar is sponsored by Novamind. Novamind offers a full spectrum of implants and prosthetic solutions that accommodate any clinical need in modern implantology. We successfully supply highly demanded dental implants types called internal hex, tissue level, bone level, and active conical connection. Our EU production unit and product quality is appreciated worldwide. Dental implants and dental restorative solutions produced maintaining all the standards of EU medical device regulatory. Products are manufactured in Athens, Greece, and distributed worldwide with more than 1 million happy restorations. You can take a screenshot of this slide, and you can check the link for more information. Now about our upcoming dental webinars. We have a webinar with Dr. Shikha Sharma about single-visit endodontics. We have a webinar with Advocate Sushan Samudrala about legal aspects of dental practice. This is part 2. If you didn't watch part 1, you can find it on our Facebook and our YouTube channel. And a webinar with Dr. Kritika Bajpai about connecting links between oral cancer and tobacco. Another webinar with Dr. Garima Goel about errors in endodontics. About our upcoming dental workshops, we have an online workshop about short dental implants with Dr. Himang Zala. The course highlights detailed online lectures, international certification, recorded session, WhatsApp mentorship, assignments, and much more. Last but not least, I would like to invite you to join our second World Implant Expo 2021, which is going to start on November 5 via virtual platform with more than 30 speakers and live interactive sessions. If you have any question, kindly call or WhatsApp this number or visit our website events.dentistchannel.online. If you're not a Prime member yet, join our family to get free certificate of participation after every event and benefit from exclusive discounts and special offers on online dental courses, on-site dental courses, hands-on dental courses, and events, workshops, and much more. If you want to become a Prime member, kindly visit our website, www.dentistchannel.online, and follow us on our social media platforms, Facebook, Instagram, YouTube, and Twitter. Okay, so now we can move on to the question and answer session.
Okay.
So, one of the doctors is asking in the previous slides, can I just smoothen the round area and the adjacent tooth as a solution?
At what slide?
In the beginning.
After if he did some damage to the
Yes,
tooth.
to the tooth.
Yeah.
Yes, to the adjacent tooth.
If the damage to the tooth is inevitable, if it's happened, okay, he will do some finishing and polishing to the adjacent tooth. What happened after you damage or after you scratch the adjacent tooth? It will increase the surface energy. The increasement in the surface energy will cause accumulation of bacteria and later on the caries. Okay, so you have to reduce the surface energy by doing finishing and polishing. Okay, to reduce the surface energy. This is what we did or we are doing after we finish our restoration. We did the finishing and polishing so as to decrease the surface energy of the surface of the restoration of our restoration, so as not to change in color or to make it an area for accumulation of bacteria. Okay.
Second question about sticky wax. Sticky wax will be very hot to put on soft tissue, right or not?
Yeah, because we don't use it on hard tissue or on soft tissue, sorry. We use it on the clamps of the rubber dam if the clamp is not 100% fit to the tooth. So we use it to seal the gaps, okay?
Okay, one of the doctors is asking about bulk fill composite. What about bulk fill composite?
Okay, bulk fill composite is a new trend, but we use it wrong. Okay, the bulk fill composite should be confined only to the dentine because the module of elasticity of the bulk fill composite is 14 gigapascal, from 12 to 14 gigapascal. Okay, so it's resemble the dentine, which is 18 gigapascal. Okay, so if we use it on the dentine will compensate the shrinkage of the composite. If we exceed the enamel, the enamel is rigid, so it will cause micro cracks. That means that I will do some drawing. Okay. Okay, this is a cavity. Okay, if we do a bulk fill here, it will cause micro cracks. Okay, those micro cracks will lead to micro leakage later on. Okay, so you have to use it before you reach the enamel, and after that use a traditional composite to cover it. It's good. But if you use it as a bulk fill for the whole restoration, you will have micro leakage, you will have sensitivity, and you will have recurrent caries.
Okay, Dr. Aisha is asking, after a few years of composite restoration, there is pigmentation. How to manage this yellow-brown pigmentation, especially in anterior teeth?
Okay, this is caused by poor polishing, or sometimes in the anterior teeth, when you do your restoration, you do your etching and bonding for the area you put your restoration on it. But in real life, the restoration may extend beyond the margin that you imagine in your preparation. So every time you do a restoration, please etch the area beyond the margin of your restoration and bond it, because you don't know where the composite will reach. Okay, so if you do an anterior restoration and you did a bevel for like a class 4, do the acid etching for all the tooth, okay, and bonding for all the tooth. Okay, then do your restoration. You will find yourself with a good bonding wherever the composite will reach. Okay, and after that, do a good finishing and polishing to reduce the surface energy. This will help you, and you will not find any recurrent caries or any staining or discoloration of the restoration.
Okay, can I put bulk restoration in dentine only, and when we reach enamel, start layering?
Yeah, this is what we talked about before.
Okay.
So you have to reach only for the dentine, leave 2 millimeters for the enamel, and do traditional composite.
Okay, Dr. Fani is asking what is indirect composite restorations?
The indirect composite restoration, when you have a case like the missing walls, you have a premolar with a missing, let's say, palatal wall, okay? You do your build-up, you do your preparation as an overlay for the overlay or the onlay, okay? And take an impression, okay? Then pour it outside the, on the lab, or you pour it yourself and do the restoration outside the patient mouth. After that, you will deliver it later on to the patient, like an onlay or overlay that made in the lab, but with composite. Okay, you will cure it more perfectly on the outside the patient mouth, and you will have no shrinkage, whatever. Okay, but don't forget to sandblast it with aluminum oxide.
Dr. Aisha is asking how to choose between composite veneers and porcelain veneers.
Okay, okay. If you have a discolored tooth, don't use composite veneers, because if you want to change the color of the tooth, you need every 1 grade of color, you need 0.2 millimeter of a preparation or thickness of the composite. So as you increase the thickness of the composite, you will have a very dark composite, okay, because of the it will be more chromatic, okay. So or you have to prepare more of the tooth. So you have a solution for that is with the ceramic one. The ceramic with minimal thickness will have better color and better strength. So use the veneers, the ceramic one at this case. But if you have if you don't want to change the color and everything is okay, you can use composite veneer so as to change the structure, or sorry, the texture of the outer surface of the tooth. This is okay.
Dr. Hannah asked us on Facebook, what about Dical? Is it fine to use it as a liner material than use GIC base too?
I think we answered this question before.
Okay, then we move to another question.
No, I can repeat it.
Yes.
We don't want to complicate our restoration. We don't want to use multiple layers of different materials in our restoration. We need to have a whole composite restoration, and we have to find as much as we can surface to bond on it. So if we use Dical, after that we use glass ionomer, then we will have a very little amount of surface to bond on it. So it's better to use only Theracal, or not use any lining material if there is no perforation, or if there is no micro perforation or shadow of the bulb. Okay, use only bonding and dentin and composite.
Dr. Aisha is asking, can we use chlorhexidine immediately after cavity preparation as antibacterial agent?
Yes, and we use it. We use it immediately, and we use it also after acid etching to prevent the formation of matrix metalloproteinase enzyme that cause the hydrolysis of the collagen of the hybrid layer.
Dr. Fani, I think this is the last question. Dr. Fani is asking, how should we bond indirect composite?
Okay, we do a sandblasting. Okay, sandblasting with aluminum oxide. And we have something called remodeling resin. Remodeling resin, we can put it, apply it on the composite restoration, the composite restoration, the onlay, let's say, and this will recreate the oxygen inhibiting layer. The oxygen inhibiting layer is the layer responsible for the bonding between the composite itself, the composite layers itself. And on the surface of the tooth, you can, if there is any composite on the surface of the tooth, also sandblasting, acid etching for cleaning, and use of the remodeling resin on the composite and bonding on the rest of the tooth, and do your cementation. But you can use, if you don't have modeling resin, if you have a 4th generation bond, you can use only the bond to recreate the oxygen inhibiting layer, not the universal one, not the 7th generation, only the bond with the adhesive bottle only, not the primer, not the primer and etching. No, use only the bonding bottle, the adhesive one.
Doctor, one of the doctors is asking how and when we use flowable composite.
I use it all the time. Okay, it's same as composite, but with more matrix, less filler. I use it when I do class 2. I put a drop of flowable composite on the base of the box and apply traditional composite without curing the flowable composite. This will seal the gaps. And after I finished my restoration and do my anatomy with the instruments, I put 1 drop of flowable composite on the surface and brush it so as to seal any gap that I don't see on the surface of the composite. And it will help me for the finishing and polishing, because with less filler and more matrix, it will be more polishable.
Oh, very interesting. I think it's fine. Oh, we have more questions. Doctor, can you please conduct hands-on course on composite restoration?
Inshallah.
Does it work online? We will talk about it later on.
Yeah, inshallah.
Can we add composite in lacking space after 1 day?
What?
Can we add composite in lacking space after 1 day?
You can. You do your rubber damming, okay, sandblasting with aluminum oxide, refresh the oxygen inhibiting layer with the use of adhesive only, the bond bottle or the remodeling resin. Also, you can do acid etching. The acid etching here is for cleaning, to remove any protein from the saliva, okay? Sandblasting, and as we said before, the remodeling resin and or the bonding agent only, and add the composite. It's good. Will work.
Okay. Can we use dicals and Vitra bond instead of Terracal?
This is the same question the 3rd time. No, I don't prefer it.
Okay. Dr. Abir is asking how to avoid necrosis tooth after composite restoration.
By knowing what caused necrosis. Is it the acid etching, the over etching? So I have to do etching for 15 seconds. Okay, is it the C factor because of the stress of the tooth? I have to do oblique layering technique. Is it the light curing? And I think it's the light curing because of the heat generation. Okay, that will appear after 2-3 months after the restoration. So you have to do a pulse delay technique in order to avoid any elevation in the heat of the restoration. Okay, you can try it at your clinic. Put a drop of flowable composite on your hand and do light curing. After 5 to 10 seconds, you will have a burn on your skin. So it's very hot. So what happens to the tooth, which is close to the bulb? It will do a necrosis because of the heat.
I hope it's the last question now. Can we do composite filling below CEJ?
Yes, I can do, but the bonding here is unpredictable. For me, I do a sandwich technique. I put reinforced or modified glass ionomer restoration, mainly Equia 40 HT, okay, on the base, and I will complete my restoration with the composite. This is the sandwich technique.
Okay, I think all is fine for now. It was a very interesting session, really.
Thank you.
Thank you, Dr. Ahmad Yusuf Alamarnah, for sharing your knowledge and experience with us. We are looking forward to planning another webinars and workshop with you in the future.
Inshallah. Inshallah.
Thank you so much.
Welcome,
welcome. It was a very interesting session. Thank you. We enjoyed it a lot.
Thank you.
Thank you.
Welcome.
Bye-bye. Thank you.
Bye-bye.